My name is Gail Burchett. I am unable to be with you due to restrictions from the coronavirus pandemic. So I will introduce myself. I graduated from KCOM in 1965, and as this slide indicates, I had an internship, residency in internal medicine, fellowship in cardiology, and I'm certified in internal medicine and cardiology, and have been teaching at KCOM for the last 58 years. The first topic that we want to consider is that of bradyarrhythmias. The term brady implies slow heart rates, normal heart rate being 60 to 100 beats per minute at rest. And so bradyarrhythmias would be heart rates of less than 60. Our objectives in caring for patients with bradyarrhythmias is to identify the mechanisms and types of bradyarrhythmias and to understand the proper diagnosis and management of bradyarrhythmias. Slow heart rates may be physiologic or pathologic and may originate from multiple areas within the heart. The diagnosis of slow heart rates depends on a knowledge of where the slow mechanism is originating, whether it's in the SA node, AV node, bundle of His, or bundle branches, or possibly even from the atrial and ventricular myocardium. This slide shows the action potentials that originate autonomously from different sites within the heart. Those that originate fastest will capture the dominant rhythm of the heart. And if you'll notice that the rate is faster for the sites higher in the conductive system of the heart. The electrocardiogram also shows the corresponding segments of the activation of different sites within the heart. Mechanisms of slow cardiac rhythms depend on these factors: the automaticity, which is faster, the higher in the conductive system, the conduction pathways, the refractoriness or recovery times. Some are absolutely unresponsive during a certain period in the cardiac cycle, while others may still have some degree of responsiveness during the time of repolarization. These factors can all be determined by tests called electrophysiologic studies to better determine the diagnosis and treatment of the arrhythmias. The normal heart rate is calculated as 118 minus 0.57 times the age, so it is somewhat age dependent, with younger patients having faster heart rates than older patients. Again, the definition of sinus bradycardia is heart rate less than 60, while sinus tachycardia, or any type of tachycardia, is represented by a heart rate of greater than 100 beats per minute. Sinus bradycardia may be a normal physiologic finding, but there are certain abnormalities that are illustrated on this slide. The sinoatrial dysfunction is times of asystole of greater than 3 seconds. We call these sinus pauses or sick sinus syndrome if they're symptomatic, with lightheadedness, dizziness, even syncope. Bradycardia tachycardia syndrome is periods of slow heart rates and alternating with rapid heart rates, and is represented by atrial fibrillation, atrial flutter, and premature atrial contractions. First degree SA exit block is when the impulse cannot exit the SA node at the proper rate, and it basically is indicated by slow sinus resumption after premature atrial contractions, and has no definite identifying features on the electrocardiogram. A second degree sinoatrial exit block is when the impulse exiting the SA node is intermittently absent, and we see absent P waves indicating this. The third degree SA exit block is when there is total lack of atrial activity and is dependent on a subsidiary ectopic atrial pacemaker, and we see this on the electrocardiogram as sinus arrest. This electrocardiogram illustrates a second degree SA exit block. We can identify this by noting that there is absence of P waves, particularly seen in the middle tracing of lead 2. The first pause there shows 2 beats probably are absent, whereas further across to the right, 1 beat appears to be absent. When the P waves are absent, its subsequent QRS complexes are also absent, and this appears much like a sinus pause, although the pause interval represents a multiple of the typical PP interval. SA node dysfunction diagnosis requires an electrical event recorder of some type, either a Holter monitor, which is the continuous recording over a period of time, typically 24 hours, or an event recorder that only records the previous 30 seconds and subsequent to any change in rhythm. Carotid sinus pressure producing pauses of greater than 5 seconds is also an indication of SA node dysfunction. The treatment of SA node dysfunction may require demand ventricular pacing, and the type of pacing needs to be an atrioventricular sequential type of pacing. We will now turn our attention to slow cardiac rhythms where the site of abnormality is in the AV node rather than above the AV node. The primary concerns about AV conduction disturbances is whether the site is high or low in the AV node bundle of His conduction system, and whether or not there is risk of progression to complete AV block with cardiac standstill. And also, will there be a subsidiary pacemaker that will take over and be electrophysiologically and hemodynamically stable? That's usually expressed whether or not the site of abnormality is in the His bundle or below the His bundle where there is greater risk. This slide shows some of the causes of AV conduction disturbances. Vagal stimulation or vagotonia may be one factor, just as it is common in SA node dysfunction. Drugs such as digoxin toxicity, beta blockers, calcium channel antagonists are also causes of slow rhythms due to AV node dysfunction. Acute myocardial infarction, and specifically the inferior myocardial infarction, may be a cause of AV node dysfunction, as well as coronary spasm of the posterior descending coronary artery and right coronary system. Acute rheumatic fever, inflammatory diseases of the AV node, is also a cause of AV conduction abnormalities. Infectious mononucleosis, Lyme disease, sarcoidosis, amyloidosis, mesothelioma, and congenital etiologies can also be causes. Two types of degenerative disease, that is Lev's disease and Lenegre's disease, have been identified where the conductive system undergoes calcification or degeneration of the conductive system. Lev's disease is more commonly associated also with aortic valve and mitral valve calcifications. This electrocardiogram was recorded from a 16-year-old girl who had a slow pulse noted on an athletic examination but was otherwise asymptomatic. She also had bruit de Canon, which is intermittent prominent pulse in the jugular neck veins, and a third heart sound and a grade 2 systolic ejection murmur at the upper left sternal border. May be physiologic and not represent any definite abnormality in themselves. The electrocardiogram, however, shows evidence of a third-degree AV block that is probably congenital and not due to any acquired type of heart disease. We see P waves that are occurring independent of the QRS complexes, and there is total dissociation of the P wave, the atrial activation, and the QRS complex, the ventricular activation. So there has to be a subsidiary site producing the ventricular QRS complexes that are totally separate and not synchronous with the P wave or atrial activity. AV blocks may be determined to be first degree, second degree, or third degree AV block, depending on the severity. First degree AV block is when every beat is conducted from its corresponding P wave, but is slow, and the PR interval is prolonged at greater than 0.20 seconds. A second degree AV block is when beats are conducted, but occasionally some are totally blocked, and we have P waves without following QRS complexes. Mobit's 1 second degree block, or Winkie-Bach block, is when there is a rhythm such as 3 to 2, that is 3 atrial, 2 ventricular, 4 to 3, or 5 to 4, and is seen in inferior EMI drugs or His bundle abnormality. A Mobit's 2 block is a more severe block, and it is infra-His disease. and is associated with wide QRS complexes that are occurring in a 2-to-1, 3-to-1, or 4-to-1 rhythm. That is, there may be P waves that are occurring as much as 4 beats in a cycle, with only 1 of them being conducted and 3 being blocked. Third degree AV block is when all the P waves that are present are totally blocked, and there is no corresponding synchronous QRS complexes. Obviously, the patient would not survive this if there was not a ventricular site or origin of a subsidiary pacemaker that's occurring on its own automaticity. The typical heart rate in this is slow, 40 to 45 per minute if it's due to His disease, and even slower, less than 40, if it's infra-His disease. The treatment for AV blocks, there's a breaking point at second degree Mobitz 2 and third degree, which require pacemaker, whereas lesser degree blocks, first degree and Mobitz 1, second degree, do not require pacing generally. This electrocardiogram illustrates a Mobitz 1 second degree AV block. The red arrows indicate the P waves, in which you see a progressive lengthening of the PR interval for the first 2 beats in the cycle, and the third P wave is totally blocked with no QRS complex following it. So this would be an example of a 3-to-2 rhythm. This electrocardiogram shows 4 identified P waves by the red arrows. You notice that the first beat is conducted, it produces a QRS complex following it, while the second beat in that cycle is totally blocked, and then it repeats itself. And so this is a 2-to-1 rhythm. And by definition, this is called a Mobitz 2 second degree AV block, where there is no progressive lengthening of the PR interval as you see in Mobitz 1. This electrocardiogram shows black arrows identifying P waves, which are difficult to see because they are rapid with a rate in the range of 150 to 200 per minute. This represents a type of rhythm that we haven't discussed yet called PAT, paroxysmal atrial tachycardia. However, you notice that the QRS complexes are not as fast as the P waves are, and so some of the P waves obviously would be blocked. So this is a rhythm of paroxysmal atrial tachycardia with block, which is considered to be a red flag pathognomonic rhythm for digitalis toxicity. This electrocardiogram shows a third degree AV block. We saw this previously in the 15-year-old girl with congenital AV block. The electrocardiographic diagnosis is made by identifying the P waves under the black arrows, in which there is a fairly regular PP interval, but the QRS complexes are not synchronous in any way with the previous P wave. So there is a separate pacemaker site occurring somewhere in the lower AV node bundle of His area. And this is a typical electrocardiogram of third-degree AV block. This is another electrocardiogram showing P waves under the red arrows that are at around 75 to 80 beats per minute, while the ventricular QRS complexes are occurring much slower in the range of 30 to 40 beats per minute. We call this Adams-Stokes syndrome when the patient has a history of syncopal episode. Probably what happened at that time was the AV block progressed to total block with no evidence of subsidiary pacemaker, and the patient basically had a cardiac arrest episode and then spontaneously recovered from it. This is fairly typical and indicates an urgent need for pacing. The term AV dissociation means that the atrial and ventricular electromechanical activities are totally separate from each other and not dependent or synchronous. The atria and ventricles are under two separate pacemakers in this, and either one may be the faster mechanism. Some examples of this: the third-degree AV block, where the ventricular pacer subsidiary pacing is slower. Isorhythmic AV dissociation, when the two atrial and ventricular rates are similar, and the a junctional P wave may be before, in, or after the QRS complex. And interference AV dissociation, which is like the previous isorhythmic AV dissociation, except there occasionally a P wave is conducted and the two sites are synchronized. The other type is when there is enhanced junctional or ventricular pacing, pacemaker site that competes with or exceeds the sinus rhythm, and this is what happens in ventricular tachycardia or accelerated junctional or accelerated ventricular rhythms, as seen commonly in digitalis toxicity, myocardial infarction, or following cardiac surgery. This electrocardiogram shows a patient with third-degree AV block because none of the P waves are passing through the AV node. Instead, there is a junctional QRS complex that is originating a regular beat of its own, and this is called junctional AV dissociation with third-degree AV block. This slide shows the guidelines for pacing in acute myocardial infarction. The first of the slides we're going to look at here is temporary pacing and may not require permanent pacing. These include patients with myocardial infarction that have sinus bradycardia with a low blood pressure and is unresponsive to drugs. It includes a Mobitz 2 second-degree AV block, a third-degree AV block, or bilateral bundle branch blocks, which are manifested by alternating bundle branch block, right and left, or right bundle branch block with left posterior fascicular block. Any new or age undetermined left bundle branch block, left anterior fascicular block, or left posterior fascicular block with right bundle branch block also are indications for temporary pacing and possibly later determination for permanent pacing. Right bundle branch block or left bundle branch block with first-degree AV block is also considered an indication for temporary pacing, and certainly a patient experiencing asystole a temporary pacemaker implantation is indicated. The guidelines for permanent pacemaker implantation after an acute myocardial infarction are shown here. If there's persistent second-degree AV block in the His-Purkinje system, that is, having a wide QRS complex with bilateral bundle branch block, or if there's complete heart block or symptomatic AV block at any level, or if there is transient advanced second or third degree AV block at the AV node level with a narrow QRS complex, these are all indications for permanent pacemaker implantation. Some special considerations for pacemaker therapy in patients with bradycardia. If there is sick sinus syndrome or SA node dysfunction, it is preferred that they have an atrioventricular synchronous pacemaker. If there is AV node dysfunction, all of them that are symptomatic with AV block of the Mobitz 2, second and third degree AV block require atrioventricular pacing, synchronous pacing. If patients have cardiomyopathy, they not only require atrioventricular synchronous pacing, but they may require also biventricular pacing, which we will see on a later slide. If there's autonomic nervous system dysfunction, an atrioventricular synchronous pacing unit is needed. And atrial fibrillation is possibly an indication for a dual site atrial pacing. This slide indicates some terminology that's used in pacemaker therapy. The first bold series of letters, AAI, AAIR, VVI, and so forth, are defined by the following indications. The first letter represents the paced chamber. The second letter represents the sensed chamber, where it's sensing the patient's beat. And the third represents the response to sensed beats, whether it's inhibited, the pacemaker is inhibited, triggered, or dual. And the next letter, the fourth letter, would indicate if it has special functions of being rate responsive to physiologic change, such as with exercise speeding up the rate. This slide indicates the treatment for bradyarrhythmias. Atropine given intravenously is the immediate treatment for just about all bradyarrhythmias, and frequently is all that's needed to speed up some types of bradyarrhythmias. Pacemaker therapy, otherwise, we've already discussed the indications for both temporary and permanent pacemakers and the letter designation of the type of pacemaker. This slide illustrates pacemaker therapy showing dual chamber leads, that is atrial and ventricular, right atrial and right ventricular leads. The atrial lead can be used for pacing as well as a sensing electrode. Likewise, the ventricular lead both senses and paces. And you can see the corresponding electrocardiographic pacemaker spike and wide QRS complexes that follows ventricular pacing. With atrial pacing, you'll see a small spike before the P wave, as in the second line electrocardiogram, showing a pacemaker spike with a P wave following it, and the QRS complex looks fairly normal in that situation. This slide shows a dual chamber DDD cardiac pacemaker and the typical lead placement. A lead in the right atrium and a lead in the right ventricle. Another new development in pacemaker therapy is resynchronization of the two ventricles, and requires both a left ventricular and right ventricular lead, as well as a third atrial lead. The left ventricular lead is passed through the coronary sinus and lies in a coronary vein overlying the left ventricle. This resynchronization of left and right ventricles improves cardiac output in patients who have cardiomyopathy. There are certain pacemaker complications that can occur if there is battery depletion or lead fracture or improper contact of the electrode in the ventricles. And as a result, the pacemaker may end up competing with a rhythm that the patient has autonomously. And the pacemaker syndrome symptoms then can be fatigue, dizziness, syncope, abnormal neck pulsations, but they are corrected with atrial pacing with synchrony with ventricular activity. This is a follow-up on the previous slide showing pacemaker syndrome of syncope, pre-syncope weakness, and dizziness, and it's due again to competition between ventricular pacemaker and sinus node pacing with dysfunction, or it may be prevented by changing a single electrode system to a dual chamber pacing system to maintain AV synchrony. Some of the factors that predispose to pacemaker syndrome is a patient who had a slow heart rate prior to pacemaker implantation and has ventriculo-atrial retrograde conduction through the AV node. The VVI pacemaker also is more prone to pacemaker syndrome, as well as patients who have a non-compliant ventricles, such as in diastolic dysfunction and cardiomyopathies. This chest X-ray shows another problem, complication with pacemaker therapy, and that is improper electrode position in the coronary sinus rather than in the right ventricular apex.